Good morning and welcome to this morning's symposium. Today, I'm very happy to be able to share that we have many eminent speakers and equally distinguished moderators who will be talking to us at this Asia Pacific Pediatric Cardiac Society Education Forum. And this is the third webinar, which will focus on transcatheter interventions in tetralogy of Fallot. I'm sure that you will all enjoy today's interaction, and we're very happy to invite our first moderator, who is Professor Masood, to kickstart today's session.
Thank you very much. It's my pleasure and honor to be here amongst such distinguished faculty, and a pleasure to introduce our first speaker today, Shai-J Chen, who is Chairman, Department of Medical Imaging at National Taiwan University Hospital. He's a very renowned radiologist. He pioneered sort of radiology in terms of cardiovascular CT imaging for congenital heart disease. He has been involved with that since 1994, after National Taiwan University Hospital installed the EBCT in the world. He has over 28 years of experience on cardiovascular CT and MRI interpretation in children and has published extensively in the field. He was the immediate past Secretary General of the Asia Pacific Society of Cardiovascular Imaging, which involves 57 countries and more than 1,500 members around the world. He's going to talk about imaging in pulmonary arteriopathy, which with focus on tetralogy of Fallot's intervention at peripheral pulmonary artery, right ventricular outflow tract, and patent ductus arteriosus. So very extensive sort of scope. Over to Dr. Shai-J Chen.
Okay, can you hear me?
Yes, we can hear you.
Okay, thank you very much, Professor Satya, for your kind introduction, and good morning, ladies and gentlemen. It's my honor to be invited to APPCS to share you this topic about imaging on fresh tetralogy of Fallot palliative interventions at peripheral pulmonary artery, right ventricular outflow tract, and PDAs. As you know, there are four major imaging modalities used to evaluate the disease heart in children. As a radiologist, CT and MRI are the tools that I want to discuss more with you. CT has the advantage of the high spatial resolution and a wide FOV, but the limitation is the radiation and the use of contrast medium. CT is very useful to define the procedural suitability and very precise to make a measurement about the target vessel and the for planning of the device size, and also is very useful to procedural evaluation. In contrast, the MRI has a good spatial resolution, although a little not as good as CT studies. But MRI has a higher tissue characterization to further differentiating disease pathology of the soft tissue, such as myocardium. And MRI has a very good advantage in the functional and the fraud assessment, which this part is CT has some limitation. However, MRI, the major limitation is a longer image time that make children, if the condition is not so stable, so it is not a good image modality of choice. And the MRI will have some severe metal artifact. So if you have some metallic implants in the field you have interest in, then MRI will be not a good choice. MRI as CT has the same ability to define the procedural suitability. But as you know, the spatial resolution is not as good as CT, so the measurement and the device sizing is not as good as CT. MRI also can be used to evaluate the post-procedural conditions. So based on this basic knowledge of CT and MRI, I would like to show you their usefulness one by one in both pre-procedural imaging and post-procedure imaging to help your patients. First, before procedures, I think the confirmed diagnosis from echocardiography is the basic. The right upper one is the typical tetralogic Fallot cases that has a VSD overriding aorta, infundibulous stenosis, and overriding aorta and infundibular hypertrophy lead to a focal stenosis. In contrast, the right low one is the double outlet of the right ventricle. So after the confirmed diagnosis, the second problem is to evaluate the severity of the pulmonary stenosis, because the severity and the different type of the PS is very important for procedure selection. In this one cases, you can see there is still a pattern of the RVOT to the small pulmonary trunk. So the RVOT intervention such as a balloon dilatation or stent is feasible. However, in the left lower one cases with very thick and dysplasic pulmonary valvular atresia, I think the RF perforation with balloon dilatation is the good choice. However, in the middle one, you can see there is interaction between the RVOT and the remnant of the pulmonary trunk. So RVOT intervention is impossible. So we should find another way to improve the pulmonary flow, such as by the next topic about the collaterals. Each collateral should be disclosed clearly to realize the whole the hemodynamic and the possible routes of procedure selection. The right upper corner one is extreme TOF at lots of markers. And these markers have a nature connected to the native PA. So in this case, procedure for markers is not emergent selection in case there are some focal stenosis. However, usually there are some associated with PDA. In this case, there is a very short and straight PDA to connect the native pulmonary artery. So the spatial resolution and the spatial relationship of this vessel is very good demonstration for you to select and the planning of the procedure. Some associated peripheral pulmonary stenosis are also very important, and each patient has different combination. Here is the focal stenosis at the junction of the PA bifurcation to the proximal RPA. And this one has also another PPS at the Highland LPA. Even after Highland part, the peripheral PS CT imaging could provide very clear demonstration to show you there the severity and the location of the PPS. In this one case, there is another focal stenosis at the middle portion of RPA, which caused by a deep folding. This PPS could very clearly and very precise disclosed by CT or MR angiography to help you to decide the planning and the interventions. Some associated anomaly may not directly impact the interventional procedure, but also should be take serious care about this. As you know, airway anomaly are more frequently occurred in tetralogic Fallot than general populations. So endotracheal intervention should be carefully not into a blind pouch of a tracheal diverticulum or one lobe ventilation into a trachea bronchus. Oh, okay, after general surveillance, you think your patients need some interventions. Pre-procedural imaging should help you clearly describe the size, the shape, and the location, and the origin, and the insertion of the target vessel you wanted to do. In this case of the PDA, this one is a large C-shaped PDA, which is more easily for you to perform the PDA stent. However, in these cases of a very small U-shaped PTA with acute bending and some juxtaductal insertion stenosis, include distal PTA side and the proximal LPA side. Also, another case has a small U-shaped PTA, and this one is another U-shaped PTA. This type of PTA is has some problem in intervention, and you should keep in mind this case will some difficulty than the large G type and the straight short straight type PTA. And then this one is another case of another type of inverted arrow type PTA with acute bending. So pre-procedure CT image with 3D reconstruction is very helpful to disclose the whole picture and the 3D spatial relationship of your target vessel and the surrounding great arteries. CT image allows you to precise measurement the length and the diameter of the PTA for device and procedure selection. But not every PTA suitable for standard deployment. In complex morphology, such as the tortuous and the very long and the tortuous stuck with multiple acute bend and the loops has a likelihood of complication and the procedural failure has been reported high. So in this case, we ask our cardiac surgeon to perform a left modified BD shunt for the patient. Coronary artery anomaly is not rare in TOF. For procedure at the RVOT, possible coronary artery crossing should be taken into serious consideration, but not an absolute contraindication. In this case, we can see the clearly the RCA rise from the proximal LAD, but had a safe RVOT stand. Another case of a coronary artery anomaly of this left coronary artery arising from the proximal part of the RCA. So before intervention, if you your target lesion, target area is at the RVOT, coronary artery anomaly should be take care and it should be surveyed before procedure. And finally, before procedure on a PTA, despite CT or MR image could provide very clear 3D demonstration and make a comprehensive measurement about the tortuosity, length, diameter, angle, lots of measurement. However, if you is possible urgent 3D printing of a real size PTA, I think it is very useful for you for rehearsal and repeated practice. During the procedure, I think fluoroscopy and angiography is your specialty. CT and MR has no load on this. Okay, let's move to the post-procedure imaging. After procedure image is used, if the patient has not reached the predicted benefit, the first one parameter is to evaluate the growing of the bilateral PA pulmonary arteries. CT McGuinn ratio has been provided a reliable measure to represent the PA flow non-invasively. In some cases, negative PA may be judged by the stent, which result in a poor PA growing. In contrast, the unaffected side of the PA keep good growing. In this case, the affected size, we can perform a BD shunt, can rescue such conditions. Instant thrombosis is a possible cause of PA growing. This is a full patterned RVOT stent. We can see. However, in this one case, some thrombosis is found at the proximal, middle, and this part of the stent lumen, which lead to the poor growing of the pulmonary arteries. A PTA stent may also have a thrombus in the lumen. You can see from the longitudinal section or cross section, you can see there are little thrombus attached on the wall of the stent, which may impair the PA growing. Stent fracture may occur in some cases, especially those with repeated balloon dilatation. In this case, we can see there are multiple stent fracture here, and also has some thrombus in the distal part of the stent. This another case is also has a disruption of the stent mesh. Distal migration of a stent can actually be overcome by adding another stent to cover the missed part. Some cases has a pseudoaneurysm after balloon dilatation. In these cases, follow-up CT 1 month later after balloon dilatation of the parietal proximal PA, you can see there is a small outpouching pseudodiverticule at the proximal of PA. We also have a growing pseudoaneurysm after PTPVs. In this case, 10 days later after the PTPV, there are two small outpouching pockets at the anterior wall near the RVOT. 2 months later, these two pseudoaneurysm grows a lot, which has been resected during total correction. Okay, this is my final slide. The CT and MR image could provide clear and very useful information for both pre-procedure and post-procedure imaging, including the general surveillance and the confirm the diagnosis and to detect the PA severity. For patient feasibility, pre-procedure CT and MR image can describe the size, shape, location, and measurement of the targeted area you want to intervention and the planning. Don't forget about the coronary artery anatomy, and if possible, you can make some 3D modeling and the printing for your rehearsal and the repeated practice. After procedure, the PA growing and to check any kind of the cause or to lead the unexpected PA growing, including restenosis or gel by a stent or some kind of instant thrombosis, and be careful to check some complications such as the stent fracture, migration, and the pseudoaneurysm. Thank you for your attention.
Thank you very much for such a comprehensive talk in such a short period of time. That was very, very useful description. I'm sure there would be some questions from the participants as well, but I was just going to start asking you, you said there are 4 major modalities which we use in terms of sort of description or in terms of assessment. Is there any measurement difference between MRI, CT, and echocardiography? Is there any literature on that, or because sometimes you do it in systole and diastole, and how do you really do it on CT imaging?
Actually, CT scan can get the full cardiac cycle of CT imaging, especially with the setup of the machine. We can get a full cardiac cycle, so we can measure both on systole and the diastole is okay. And by the inherited spatial resolution, CT has, I think, the highest and the best spatial resolution for target area measurement.
Okay. And in terms of sort of stenting and post-stenting evaluation, do you really find any major differences in terms of measurements, or it doesn't really matter?
I don't have a study to compare my measurement on the CT image and the real size. I think I don't think it's a problem because the I think I'm not sure because I think the spatial resolution is very high. Yeah, it is higher than echocardiography and MRI.
Okay. Any other questions from any of the participants? Yeah, sure. Please, Frank, please go. Please go on. Please go
Okay. Yeah, I think you raised a good point there, Masood, with regards to post-procedure imaging. Because on echo, you can't always very well see the branch PAs, especially those that have branch PA stenosis, which you showed very nicely on your CT images, Prof. So I think what is important is that sometimes when you have branch PA stenosis, you might gel the stenosed pulmonary artery and you get less flow and therefore poor growth of that vessel. And I think echo can be very difficult to make an assessment of. And we use quite a lot of CT imaging after stenting, say 3 or 4 months when you are not satisfied with your echo images. So I think that is very useful. And secondly, with regards to your first question, Masood, yeah, maybe at this point of the patient's journey in terms of treatment, when all they need is palliation, the main thing is actually imaging of the anatomical imaging. And maybe MRI as a functional form of imaging may not be as important. That might come later, but I think primarily CT provides a very good anatomical imaging. With regards to that, how's the dosage of radiation with your studies for CT scan, Prof, in neonates? Are you concerned about that?
Yeah, we also consider about radiation exposure, but as you know, if you have a state-of-art new CT scanner, and the manufacturer also very take care about the radiation doses. So in my own experience, I think nowadays radiation exposure is much lower, maybe lower than 10 years ago or 5 years ago. And in newborn, we also we can get a clear imaging with less than 1 millisievert X-ray exposure. I think the state-of-art scanner has also very take care about the radiation doses.
Okay.
Yeah. I think the CT has really revolutionized as how we look at these children, and particularly in terms of planning an intervention. Is that a routine, Masni and others who have a lot of experience in neonates? Is that a routine that you would go for a CT before actually going for angiography, or is it that you would go for an angiography in most patients, but where you have a concern on a routine echo that you would go for a CT scan?
I don't think it's a routine. I don't think it should be used routinely to evaluate this targeted lesion to be intervened. I think if the echocardiogram has some limitation, has some area of uncertainty, then CT or MRI will be prescribed, and we can provide additional information for help the patient. I don't think it should be used routine.
So if you had a choice between CT and MRI, which patients would you go for a CT and which patients would you go for an MRI before planning an intervention?
I see. If the patient is stable, then as you know, MRI usually need a longer scanning time. If the patient is stable and is large enough to keep a cooperation with the whole breathlessness, then MRI is a good choice because there has no radiation exposure. However, if the patient is not very stable and you need a very quick examination to lower the risk of during examination, I think CT is better.
Okay.
Back to your question just now. I presume everyone certifies patients who goes for CT pre-imaging, who don't. So just to get opinion from the panelists, how much in terms of threshold for doing a CT prior to angiograms? Is it most patients or less than half? Just rough number.
Sure. If you ask me, Masni, I think maybe 10, 15, or at the most 20% of the patients. Otherwise, we would just do an echo and go for an intervention. But that's the threshold. But I'm sure, I think we would be happy to listen from Frank and other people.
Frank and JK.
This is a great question. You know, I'm an old school guy. I grew up. Sorry.
I have a rough data maybe provide to you in my institute about 100 echocardiography patients. Only 10 cases refer for CT examination, and maybe only 5 cases need MRI examination for further disclose the the uncovered part of the echocardiography.
Okay.
I think that answers the question as well. But Frank, you were going to say something. Please go ahead.
Yeah, I was going to say that, you know, I grew up in the era before we had all these fancy imaging, and so you know, I'm old school, and most of the time I go to the cath lab with the echo findings, and I'll figure it out in the cath lab. So, but I know that there is definitely use in the MRI for functional studies to at least even show the indications for when, let's say, for example, a pulmonary valve is indicated. But in general, if it's about anatomy, like branch pulmonary artery stenosis, even for the PDA for stenting, I will rely on my own angiography.
Okay. I think great talk. I think we already done with our time, and it's time for the next talk. Thank you very much, Shaiji Chen. That was an excellent presentation and a great talk. Great pictures as well. Thank you very much.
Thank you. Thank you for your comment.
So the next talk is a role of catheter intervention in peripheral PS in tetralogy followed. This Professor Franking will give this talk, and Professor Franking will give this talk. I think everyone in this area is familiar with Franking, so I will not waste the time to introduce Franking, but he's now working in UC Davis Children's Hospital. So please, Franklin, proceed your talk.
Well, thank you very much, Yuko. I want to just thank the organizers for inviting me to this lovely conference and to give this talk. So I'm just going to let's start with the surgical role. Now, obviously, for branch pulmonary stenosis and tetralogy flow, I do think that there's a role for the surgeon to do PA plasty, especially in the proximal branch at the time of the primary repair or at the time of a reoperation. Let's say, for example, when a valve needs to be replaced. Certainly, there is a large role for the transcatheter for the interventionist. That includes postoperative stenosis for the proximal branch stenosis, as well as any of the distal branch stenosis even at the time of repair. We know that the surgeons do not do an adequate job when it comes to distal branch pulmonary artery plasties. Now, I actually think that the management of peripheral pulmonary stenosis in tetralogy flow is not unique to tetralogy flow, but it's a very common, the same kinds of issues we find in other types of congenital heart disease that also develop branch pulmonary artery stenosis. That would include pulmonary atresia VSD, which in my mind is a severe form of tetralogy flow, detransposition, truncus, DORV, and then all kinds of single ventricle variants where any mild branch stenosis can be a problem. To me, the most important thing is the difference in how you coordinate the timing for the surgical repair of these lesions. Now, of course, I do think that for the single ventricle, we need to be more aggressive since there's no pumping chamber to pump the blood through the lungs. So branch pulmonary artery stenosis is a heterogeneous lesion. It's not just one thing. We use the term branch PS, but actually there are many forms of that. Right? Depends on the location of the stenosis, the morphology of the stenosis, the combination of the stenosis. It could be native or post-surgical, and all of these lesions I just listed. It could go from very simple to complex. So there's a simple stenosis after a BT shunt. You can see that there's a scarring at the site of the shunt that can cause stenosis afterwards. This is more of a mild branch stenosis, and these are the easier ones that can be done quite easily. This is more of a discrete orifice stenosis that becomes a little tough because you can imagine putting a stent to open that up. You might potentially jail the opposite of pulmonary arteries. This is a long segment stenosis. This is a long segment stenosis with a hypoplastic lung bed, typically due to severity of the stenosis as well as just the chronicity of it. You can have bilateral stenosis, as in this case. You can have bilateral long segment stenosis. You can have all kinds of folds, bends, twists postoperatively. Now, it's important to recognize that if you have an osteostenosis, your angulation needs to be precise. Now, this is where CT scan can help you in advance, but look at this, you see that there's a RPA stenosis, and if that's all you see and you didn't pay attention, you might say, that's all I need to take care of, which is the right lung. But actually, if you look very carefully, you angulate this, cranialize this, and you actually find that if you get the right angle, that also has a stenosis at the ostium of the LPA, which was superimposed by the MPA. So it's got to be, we have to make sure that we see the ostium when we do these, because that can always be missed unless you have a CT in advance. You can have this, in this case, a pulmonary atresia with MAPCAs, right? You can have a tiny little PDA to native but hypoplastic PAs, which can be a big problem if you don't grow this in time so that you can have reparative surgery. You can also have compression. Here's a RPA stenosis, and if you look at the levo on this part, the middle, you see that the contrast is kind of light there, as if there's less contrast in that region. And on the levo, you see the anterior ascending aorta coming around. That's probably the part of the reason why this part of the RPA is compressed. So here's a stent that went in, and of course you can see that on the lateral projection, after a while, you have restenosis, and you see the compression causing fracture. Of course, we can stent that again, but just to prove you that you can have compression causing a stenosis. And no matter what the surgeons say about putting a dilator in that can fit a certain size, you can imagine the compression will not be showing up when you put a dilator through, but once you take the dilator out, it will compress down. This is the same patient where we end up having to add an additional stent to give more support to round out the stent. You can have folds and kinks like this, all kinds of issues. So here's an example where you see a stenosis right at the ostium of the LPA, but if you look at these wire and then the stent in place, it actually open up the fold. So without having even infused the stent, just having the stiffer wiring system, you notice how much bigger the orifice is. So clearly this is not a fixed obstruction, but probably a bend or a fold that then straightens out with a stiffer wire. Of course, if you pull this balloon out and pull the wire out, it'll come right back to the stenosis. So we can't get ourselves fooled by the fact that when you put a wire in, everything looks good. So of course, we end up stenting this. You can have complex stenosis involving the lobar branches, right? Here's a pretty good examples of both proximal branch as well as lobar branch stenosis, and bilateral for that matter. You have these very complicated bifurcation stenoses, and even occlusions. So I think that pulmonary artery stenting in infants and small children is typically complex and difficult simply because of the small size of the patient and the fragile hemodynamics. However, it is also the best window for vascular rehabilitation. And we know that pulmonary artery development and growth, there's 2 more levels of segmentation after birth, and 80% of that is completed by 2 years of age, another 20% by the time you're 8 years of age. So if you get out of that window before you do the rehabilitation, you are out of the window for better growth and the segmentation of the branches. So it's important to do it early, but that's also the time when it's most difficult. We have to have a long-term strategy. Our job is not to say, here's a branch pulmonary artery stenosis, to put stent in and go back, have them go back to a referring doctor. There's got to be a communication that whatever we do for these patients, there's got to be a long-term plan for how to manage these stents from childhood to adulthood. So the stenosis is also important to recognize the adjacent structures, especially the upper lobe branch. Short lengths in infants is a problem because we don't have stents of every length size, right? So of course, there are many strategies developed to form hybrid stenting or even tailoring, modifying the stent to fit the anatomy. So here's an example of a 4.8 kilo baby who had TET repair, and you see how there's a whole hypoplastic left lung with very hypoplastic lung bed. We put the stent in, we actually put a stent in that can get to adult size, and we follow up with further growth. And you see that just by putting the stent in, you see how much better the distal vessel perfusion is just from getting more flow there. And then 5 years later, the LPA is almost the same size as the RPA. Again, there has to be a long-term plan to how to further dilate, when to further dilate, and how to follow these patients as they grow. We need to know the PA anatomy well. That means the location of stenosis, whether it's the branch, the orifice, and multiple levels of the severity of stenosis. We talked about that adjacent anatomy. We have to anticipate the potential complications associated with the details of this anatomy, such as jailing and obstructing side branches, compression, a predilation? Do we use do we need to use cutting balloons? Again, as I said, the long-term strategy is needed from infancy to adulthood. Therefore, it's really important to select the right size stent, and that means selecting a stent that can get to the normal adult size of that vessel that you're stenting. And they're different, whether it's pulmonary, proximal, or lobar, or segmental. You know that they're going to need multiple caths if you put a stent in a grown child, and so therefore the rehabilitation process is not a one-time deal, but multiple long-term. So here's a good example of a kid who, again, this is a trunk, is not a tetralogy, but you see how severe that is. We can see this in tetralogy as well, right? So of course it's bilateral. This kid is very sick. RV is not squeezing very well, and in order to get the stents in, we actually had to tailor this stents because it's such a short length. So basically you can take a stent, cut it to the length you need. And again, I primarily use the Genesis XD stent because those cut very well. You put this one in this particular case into 2 balloons, one wire to the upper lobe, one wire to the lower lobe. And you can just put it, overlay this with the angiogram. You can see how this is going to be done in a hybrid procedure with your surgeons. One wire goes to the upper lobe, the other one goes to the lower lobe. And the single stent gets right into the proximal branch without going to one or the other. So this is the stent. I'm going to magnify it for you. You can see how the original stent was put in with that 1/2 of the cut. We actually put in 2 double stents beyond that to the upper and lower lobe branches to open that up. The other half of the stent we put on the LPA, and we actually added 2 more stents there. So you can see that we can rehabilitate this. This is what it looked like at beginning. This is what it looked like at 15 months later at follow-up. You can see how much better growth there is, especially to the right lung. This patient, another patient with a very short LPA stenosis between the left upper lobe and the origin. So you can imagine that putting a stent too far in will block the upper lobe, too far out, you'll block the other branch. So it's very important to use a short stent. So in this case, once we made the measurements, we realized that the length that's needed is about 10 millimeters, 10.6 millimeters. So if you take the Genesis stent and you cut one frame, one roll, which is about 3.5 millimeters, you then have long enough of a stent that does not jail the upper lobe or get it too far into the main branch. So you see that there are 4 rows instead of 5 rows, and we put that in and we can open it up. You see there's good flow to the upper lobe on the lateral projection. It doesn't block the RPA as well. And of course, this is the pre and post, and there's a good positioning of that stent without blocking anything just by modifying the stent. A follow-up year later, you see there's still good growth. You can continue to further dilate this as the child grows. Right and left branch pulmonary artery. Now, I'm going to talk about the bilateral osteostenosis, which is a big problem because it needs a lot more care not to jail stents. Here's an example of a transposition who had arterial switch, and we basically have to do simultaneous double stenting to get it better. Again, a lot of these do not require another surgery at this point. So this is a pulmonary artery bilateral lobar branch stenosis that we can actually put double stents in. We actually balloon the upper lobe, balloon the lower lobe, and then put double stents in. And then, of course, over time, we further dilate this. You see the much better the flow into the distal parenchyma. And this is the pre, that's the post. After 35 months and 4 caths later, again, this is just to emphasize that many of these patients need repeat trips to the cath lab to overall rehabilitate these vessels until they're adult size. This is a 9-year-old kid who actually had a tetralogy fellow with a pulmonary map because I had a very complicated surgical repair with a transannular patch and a conduit, and had bilateral severe stenosis and had multiple stents put in, and the LPA, RPA, right upper lobe, right middle lobe, right lower lobe. And of course it comes to us, and I'm going to show you just how complex these can be. That's the original angiogram. This is after the stents were put into the RPA and LPA, but you see how the lobar branch is also very tight. We further dilate this, and then we start to add stents into the upper and lower lobe. And now, of course, at this point, when you further dilate, you don't want to further dilate one and then cause compression on the other. So you have to do double stenting there, double ballooning there. And then, of course, now that you have 3 vessels that are almost like a trifurcation stent, you have to further dilate this using triple balloon techniques. These gets further dilated, and this is what it looks like from the original to later on. He's now 10 years old and he's doing quite well. So it's very complex. Again, what happens when you don't make these plans? So here's an example of what happens when you don't do this. So this 5-year-old kid with the same type of lesion who had unifocalization, had an RV to PA conduit put in. The conduit was replaced, And then, of course, there's bilateral stenosis. They put a stent in the RPA. And this was actually from another center. 3 years later, the SATs are down 50 to 60%. Again, a long time between follow-up. The patient had a complete occlusion of the RPA and severe conduit stenosis, and there's residual LPA stenosis. And of course, at the other site, they were not able to recannulate the RPA, and they were told, the patients were told, there's nothing more that can be done. Go home and basically live out your life the best you can. That's kind of a sad answer. So they came to us for further management. Here's the example of that. This is a stent that was put in a conduit. You can see that there's severe stenosis at the bifurcation, and the right lung is pretty much gone. It's totally blocked off. In fact, the left upper lobe is the only lobe that the child can live off. And so basically we had to go in there and prove to ourselves that the distal branch is still open. You can see there with a wedge angiogram in the pulmonary veins. And so therefore we knew that there is still, if there is a way to get in there, we can open up and get flow to the right lung. So this is basically a deflectable sheath that we put in to give us a little more support. You can see that we looped it around the right atrium to make sure it doesn't back out, and we're able to run the wire, tiny wire through that. Eventually we ballooned it all up. I'm going to go quickly here. And we opened that all up. Again, that's not perfect at this time, but we gave them better saturations, and at least, and now the sats are in the 80% range. And that's what we ended up with. So you can see how you went from that to that, and at least gave the saturations a little higher so that the child feels a little bit better. Again, sats went from 50 to 60 to about 80%. And of course, afterwards, once we were able to do this, eventually we found some of the other collaterals that was jailed off, and then she was sent to a surgeon at Stanford, Frank Hanley. We call this the Hanley Special because everybody knows that he's probably the world's best person to do branch stenosis unifocalizations. She actually took the patient, changed out the conduit, unifocalized some of the collaterals that were not put it together, and then ended up with this. And he sent me these pictures, just showed me that the saturations are now at 100%, and the RPA pressure was 39 with the arterial pressure of 86. And here's the tricuspid, the TR jet was low. You can see this is how she looked like when we first started. See how blue she looks, and this is what she looked like after. So it actually warmed our heart to see the improvement in her. Restenosis, you can see how this is a branch stenosis, but again, if you jail it, this is what happens. And again, you just have to know that that could happen. This is an upper lobe that was jailed. The stent selection is important, so I like to use open cell stents like the Mega LD. We don't even have the Genesis, the double struts anymore, but the Vallejo stents can actually do the same thing where you can balloon through the side hole. So you see this is a rotational angiography showing the severe stenosis and the upper lobe taking almost like a 90-degree from that. We stented that, put the buddy wire there, and you see how then we can balloon it up. It doesn't look so great. We put the stent in, and of course you see the upper lobe is jailed. So now we can actually go in there and open up the side. This is what the angiography looked like. You can see that the imaging shows that the hole where the orifice is located, so it's done quite well with that. Again, having those open cell stents can be very helpful when you think that you might jail the upper lobe branch. So in summary, we need to establish a long-term plan and interventional strategy for peripheral pulmonary stenosis, especially for complex branches and in growing children. Again, preferably early in life in less than 2 years of age. Therapy options include surgical PA-plasty, balloon angioplasty, cutting balloons and stents. We need close collaboration with the surgeons, and then also a well thought out stage plan over the growth period of the child. We should anticipate multiple trips to the cath lab for serial rehabilitation as the child grows. And that could be a combination of angioplasty and stent. We start proximally, work distally. And hypoplastic branch pulmonaries require early and aggressive rehabilitation in order to optimize flow for normal growth. When stents are small, when I say small, I mean 6 to 8 millimeters, we have to anticipate the risk of restenosis, or in a grown child, anticipate the need for further angioplasty with possible additional stents. The normal RV pressures and low gradients may not necessarily mean good flow to all the branches, because you can have compensatory flow to the open branches. Distribution of the flow needs evaluation. So therefore, flow scans, MRI can be very helpful. We have to educate the family and the referring physicians about the need for close monitoring and early referral for reevaluation. Thank you for your attention. I'm going to unshare.
Thank you very much, Frank, for your wonderful talk. And I think there are some questions, but I have questions about what do you think about the biodegradable stents for children?
Yeah, I think that's a great idea, but I know we're still a little bit off. In terms of biocompatibility, there's some stuff being worked out on the coronary side by the adults. I actually think that could be a solution in terms of getting rid of the material so that you don't have to keep further dilating them. But I still think that that's not prime time, and certainly it's worthy of the investigations at this time. I'm hoping that the companies who make this will make them in larger sizes. That's the main worry I have right now. They're still in the coronary sizes, and so it'd be great if we can get them to at least a little bit bigger. But definitely, that's to me something that can be further developed.
Okay, Wallace has the question for you: how to cut the stent?
So it's a great question. I mean, I took a long time to figure this out, and it evolved over time. I found that of all the different stents I have in my hands, the Genesis stent is the best one to cut because it has got that sigmoidal hinge, and if you cut it, it's counterintuitive. Most people think you want to cut that strut as close to the edge of the stent that you're going to use as possible. But actually, you need to cut at the other end. So you leave the free end on the stent you're going to use. And the reason for that is because if you take a balloon and inflate it with that edge, that metal is so soft, it will bend away from the balloon. But if you cut it very close, it doesn't have enough length. So it'll just dig into the balloon. So you have a higher chance of causing a balloon rupture if you don't leave those edges on. Now, some of the other stents don't have the sigmoidal hinge, so they're very stiff. And I think those have a higher risk for a balloon rupture. But the Genesis actually works very well.
Thank you.
And also, in terms of scissors, I find that the typical ones that are used for suture removal works very well.
Oh, really? Okay.
I have a question.
Yeah.
Sure. Frank,
Hi.
you mentioned that the PS theory may caused by fixed stenosis or just caused by the folding or kinking. Is there any difference in stent selection? I mean the size, or any difference in stent deployment technique between these two kinds of mechanisms?
I don't think there's any major differences whether it's a fixed obstruction versus a fold. That's why a lot of times the surgeon says, I put a dilator into 10 millimeters, so it should fit. But again, if it's a fold, it's going to be dynamic, right? So certainly, I definitely measure the distal size of the vessel to make sure the stent is at least to that size. Sometimes I can oversize it by 1 or 2 millimeters. But I think that just by opening the fold, there's enough of this sort of angulation pressure to keep the stent in position. So I'm not that worried that it's going to be loose.
So do you think the outcome is similar, I think, in terms of stent embolization or migration?
I have not experienced that, but, again, I probably need another lecture to talk about some of the subtle techniques because it's just so much to talk about. But certainly there's, anytime we do osteostenosis, there's always a risk because you just have to be so perfect in putting in. If you put it too far back, it'll block the other side. So definitely you're using the proximal part of the stent as you're anchoring. But so certainly we know technically osteostenoses are much more difficult, but I don't think it's different whether it's a fixed stenosis versus a fold.
Thank you.
Okay. So because for the interest of time, we have to move to next speakers. So thank you, Frank. See you later.
See you later.
Right, thank you. So I'm Dr. Robin Chan from Hong Kong. So I'm going to introduce the next speaker. It gives me great honor to introduce Dr. Matthew Alvey again. Matthew does not need any introduction, actually. He is a very renowned pediatric cardiologist, interventional cardiologist. He's very well decorated and receiving the CSI Asia Pacific Achievement Awards in 2019 and the PICS Achievement Awards 2020. He is widely published in lots of areas, especially including his experience in PA-IVS management, in RVOT and ductal stenting. Without further ado, I'm going to let Matthew go on to with his talk, which is titled Palliation Strategy in Symptomatic Neonates with TOF, RVOT stent versus ductal stent. Matthew, please.
Thank you, Robin, for a very kind introduction. And thanks, JK and the committee in Taipei for inviting me to this excellent symposium, and happy to meet you all again. I'll be just online. Can you hear me and see my screen?
Yes.
You can? Okay. Right. I'm just going to focus on TOF with antegrade flow, which means that TOF without pulmonary atresia, and the role of palliation is still there, despite all the advances that the surgeons, our colleagues in the surgical side have achieved over the years in terms of getting excellent results in TOF repair for various reasons. One is body size, number two, the complications, as well as the long stay in ICU for neonatal repair. And then there's others are like the anatomical limitations, such as small branch PAs or very, very hypoplastic annulus, which might preclude excellent results following early surgical repair. And these are the things that I want to focus on, even though there are still options for other forms, more conventional forms of palliation. Right, if you are to choose between RVOT or PDA to stent in these sick babies with symptoms of hypoxia, cyanosis in young infant or neonatal TOF, RVOT is reasonable and PDA stent too is reasonable. The only thing is that in terms of PDA stent, by the time they present to us, usually 3, 4th week or even beyond, the PDA has already closed and might be resistant to prostaglandins, and therefore you really don't have this option in the majority of patients, I would guess, those who present at least beyond the 4th week of life. On the other hand, it might be feasible, I'm not sure whether all, because you have patients who are very symptomatic with a lot of spells, but in between spells, their sets may go up to 95 or 100, and therefore these patients tend to have fairly big RV outflow tract and annulus, which means that it might be difficult to put in a stent without expecting complications such as stent migrations after implantation. But on the other hand, we have a far wider experience in terms of experience in implanting PDA in stents, and there are a lot of publications on it, and we understand better the morphology as explained earlier by Professor Chi, as well as what we have learned with regards to difficulties, techniques, and complications of PDA stenting. And this will be my main area of talks for this session. Access, we have this is better because venous access allows us to stent RVOTs even in small patients less than 2 kilograms, whereas it is not feasible if we do this in the PDA stent unless we intend to go through the venous side through the VSD and ascending aorta. In terms of physiology, it has been argued that RVOT stent is more efficient because what we do is we push more venous blood, systemic venous blood into the pulmonary arteries, and therefore this does not cause LV volume overload, but I'm not very sure in terms of practicality whether this really matters. And number two, if we have branch PA stenosis, RVOT stent is superior because it promotes equal flow into both pulmonary arteries, which we don't have if we have a branch PA stenosis in the case of PDA stent. So I'm going to talk about all these issues in my talk with regards to technical difficulties comparing RVOT versus PDA stent, because we understand how difficult it might be in some of these cases of RVOT stent, because we are working inside the heart and all those issues of small patient size and the fragile condition of the neonate, as well as the proximity of those important cardiac structures in the right heart, which might be jeopardized by what we do in terms of maneuvering stiff wires, catheters, and stents. As long as we do surgical repair, say below 9 months of age or 9 months after the procedure, it should not be a problem in terms of reinterventions. The stents will take us through to up to this age group or period after stent implantation. But what is important is impact on surgical repair and subsequently, because one thing that was raised frequently is what about pulmonary valve preservation? Some patients, yes, they have very nice pulmonary valve annulus, nice thin valve cups tissues, and it is a shame if the stent really makes it not possible to preserve that valve, whereas this is not really an issue when it comes to PDA stenting. But on the other hand, when we have branch PA stenosis, which is thankfully not that common in TOF with pulmonary stenosis, there is the need for the surgeon to address this branch PA stenosis when it comes to surgical repair. But then again, one of the issues that is it really feasible to remove the stent in total in all these repairs? Our surgeons tend to go for this total removal of the stents. I think it's good to remove all metals if we can, but I think if you do the surgery later, they say that after 9 months or after 1 year, this may not be feasible and they may have to leave behind the posterior part of the stent in the RVOT. Right, and this is the reason why I like to talk about this more, because one, we still lack a cumulative experience in terms of what happens when we do the RVOT stent in some of the more difficult cases, because anatomically, what we do is that we try to put in stiff catheters, sheaths especially, across the tricuspid valve, make it turn three-dimensionally towards the RVOT to implant the stent. And this is in real life. This is the septal muscle, and this is the parietal muscles, which are very hypertrophied, causing the very severe narrowing of the RV outflow tract. And here is another example of a specimen with TOF with severe RVOT obstruction. And in the neonate, these distances are very small, and having to negotiate all this with a stiff sheath might pose one, hemodynamic problems, and number two, injuries to the valve structures that we are dealing with, for example, especially the tricuspid valve, as well as might be the possible perforations in the area where we are working. So this is what I meant to elaborate further, that the 3D geometry of the RV and the heart structures is very complex, and trying to negotiate this in a small neonate who weigh, say, less than 3 kilograms might be deleterious. And regardless whether you use a coronary guide catheter or even more when we use a Mullin sheath type of long sheath that has a stiff dilator, trying to negotiate in that kind of path can be deleterious to the hemodynamics, and number two, in terms of injury to the cardiac structures. Secondly, landing zone is important, because in an RVOT stent, what we do is we implant a stent and hopefully it stays there, but this is contractile tissues. And if the patient has big infundibulum in between the severe spells with sets reaching up the mid-90s, then you might be at risk of losing the stent. And you might have to put a big stent so that it sticks, anchors in the pulmonary valve annulus. But then again, if the stent is too big, that might cause torrential flow to the lungs because of the big VSD, and that will be causing other problems instead. I think we have learned, this is from the first major publication from Birmingham. There was one paper much earlier in the early 90s from Toronto, but the numbers were very small and people were not very keen on RV stenting at that point. But here is an experience from 60 RVOT stents, and these are the issues which I think are related to what I have alluded before in terms of the anatomy of the RVOT that might lead to such major complications, which can include tamponade, which can lead to death, and also injury to the tricuspid valve causing severe regurgitation, which might need an unplanned emergency intervention. And then the other thing is that because of that contractile tissue as the landing zone, the possibility of stent migration is significant, and one has caused perforation and hemopericardium in one patient, and the other stent has migrated to the transverse aortic valve and transverse aortic arch. And you can imagine that this is a neonate, say 3.5 kilograms, trying to capture a migrated stent in the aorta is a very big job, and also dangerous, I would say. And I think if we have this kind of issue, it's probably best not to try to retrieve it, but go for the surgical path instead. But this is an example, a typical case. This is 5 weeks old, 3.2 kilograms infant with TOF with frequent spells, and this is how the echo looks like. Severe sub-valve obstruction. The valve looks nice and pliable and thin. Small, maybe half annulus is half of the aorta, and this is the angiogram showing exactly what we see here with the prominent infundibular muscle, and here is the parietal muscles hypertrophy. But the patient also has a PDA, a right aortic arch, with the PDA coming off at the base of the left innominate artery. So you have really, this is a luxury. You can either go this way or you go this way. And this really depends on what is your preference, your experience, and which one you're comfortable with. Do you go inside the heart and try to negotiate all this to implant a stent, or you go for the artery? That is really a personal choice, or maybe institutional, as well as what our surgical colleague prefers. But for now, I just want to focus first on RVOT stent. So what comes to mind, I suppose, for people who are starting out doing this procedure is that, what shall I use? This is a typical 3 to 3.5 Asian neonate, maybe age up to 4 to 6 weeks. Do we use a coronary stent, or do we use something bigger, a peripheral stent, which can go from 6, maybe up to 8? More than 8 millimeters is probably going to cause severe cardiac failure if you implant such a stent in a young infant. Well, the issue is that I think when you want to implant a stent which is bigger than 5 millimeters, you need to use this kind of sheath with very stiff dilator. And imagine if you need to do that across the tricuspid valve, very shallow RV, a lot of muscles there, and very tight RVOT, very small main, and even smaller the branch PA. So this is one of a particularly difficult case, and you really have no PDA to stent despite prostaglandin. So I think as in the pre-session discussion, Frank was mentioning about the coronary stents, and this is what is probably best used for this kind of age group, this kind of age size patients, that coronary stents, you use very soft wires, and you use a catheter to first to get the wire in, and number 2, a 5 French catheter to get into that RV or near the RVOT for the stent delivery and implantation. So the biggest, unfortunately, the biggest coronary stent is 5 millimeters. That's what we have anyway here in this country, and Asians don't have big coronary arteries. This can go through a 5 French sheath or guide catheter, but that might be very tight, and you might better off using a 6 French. But you have a small neonate, maybe you can limit yourself to a 5 French sheath, and also a 5 millimeter stent. And with maximal inflation of pressure, say 18 millimeters, you can get up to 5.3 millimeters, which I think for most patients, that will take us through up to 6 to 9 months for the surgical repair. So I suppose small patients, neonates, this is the way to go. But when you have a bigger patient, for some reason that you still need to palliate, then there are a variety of stents available. For example, the renal stents, also the branch PA stents that, sorry, Frank has mentioned in his talk earlier. But this is a typical case of TOF with severe spells that needed a palliation, because our policy is that if possible not to do repair in a neonate. And this is the typical RVOT looking on the echo. Length is about 12 millimeters or so, and this is the corresponding elbow RV angio, which you can see as well. And normally we need to do a better angio once we were set up in terms of having wires and sheaths through. And this is what we normally use to get a wire up across the RVOT into the pulmonary artery for the stent implantation part. So yes, I think once you have a wire, you can change this to a 5 French guide catheter, a GR catheter, and here you do more focused angiogram to look exactly where the muscles are, and these are the infundibular and the parietal muscles. The valve is over there somewhere, and this is foreshortened, and this is what we see on still pictures. You freeze them and show exactly where is the narrow part which you must stent and where it is safe to stop where the stent should be. And on the lateral angiogram, you can see that this is like a big, and the rest is basically stenosed, hypertrophied, small orifice infundibulum. And on this, we measured 13 millimeters, slightly longer than what we saw on the echo, and we elected to implant a 14 millimeter length stent, 4.5 diameter. And this is a stent in place. So the important thing is that from the previous angio, we know that we shouldn't push it beyond because we might miss that that part of the stenosis down below. And number two, we also don't want to go too far forward because we really don't want to catch the valve cups, because this valve looks nice with good annulus, thin pliable valve, and this is post-implantation nicely positioned stent, which is not catching the valve, but at the same time covering the most important part of the RVOT, and this is the echo. That is what we see immediately post-implantation. So this is all and good, but not all patients end up like this, and I want to show some examples that are suboptimal or even not good results. So one example, one pitfall is that it can be difficult to evaluate. You do that on echo, you do that on angiogram in terms of what length of stent you need to implant. And this is what we measured, I think, about 30 millimeters in terms of length on the echo. On the still picture here, these are the very thick muscles causing severe, almost nerve flow across during systole. And this is the part that we really need to cover here. This is the bottom part of the RVOT, and this is the upper part of the RVOT. And it's probably okay to go across the valve because the valve is not big valve. Sorry. And these are all still pictures showing where we should be aiming at. On the lateral, the two very hypertrophic muscles, that is the infundibulum with a string, just a narrow thread of opening on the lateral, and this is the beak where it starts. So we thought we were in the right place, so we placed a 16 millimeter length because what we measured about 13 millimeter on the angio before. So we thought that would be safe, and with that kind of diameter, we thought, yeah, okay, this is the beginning of the narrowing, and that is after implantation. This stent ended up too short. We don't really cover that part below the stent. There is still the thick muscles with the narrowing there, and this is really not wise not to proceed and put in a second stent because that can lead to severe symptoms still after the implantation. On the AP, you can see again the two muscles causing the severe narrowing below where the stent is. But there is a problem quite often we encounter because the way it angulates, and you really have to go down and up across to put in a second stent nicely within the first one with a good overlap. And this is something that is difficult. If you have put in a longer stent at the start, then you won't have this problem. So I really couldn't go any more deeper than this, but we thought this is sufficient overlap. And then once you have overlapped the stent, you put in inflate that part to tack one stent over the other, and this is the end results. You can see that, yes, there's nice flow throughout, but that part is not covered well enough. You can see on color Doppler that there is a bit of narrowing there because of the inadequate coverage that overlap between the two stents here. But that is good enough for this patient. Within 6 months, he goes to surgery and he had a good outcome after surgical repair. This is even more difficult. So you might be still ending up too short. Also, you might have too small a stent. So if I had not covered enough at the bottom end in this patient here with very severe hypoplastic pulmonary arteries, very small valve, small annulus, and very, very tight RVOT obstruction here, you can see that just like a string on the AP view, on the aleocranial view, and this is in the aleo view. You can see a lot of muscles below the valve, which is very small, and also this valve is dysplastic and thick and stenosed. So we had this is estimated to cross both the annulus as well as the bottom part, 19 on measurement. So we chose a 20 millimeter stent. We thought that should be covering enough of this RVOT, and here you go. We can't really advance beyond that with the JR guide, but and so that led to having the sheaths curling up in the RA. But still, we thought that is a nice position of the stent. We expanded the stent, and wow, I mean, this patient really did not have enough coverage on the distal end, that you can see the thick distractive valve still not opened, and therefore we needed to put a bigger stent here, a 6 millimeter stent, and this has to be delivered by a sheath that it has a stiff dilator. Managed to do that, and this is the end result. Still, it's hard to know how this patient is going to do, because the branch PAs are very, very hypoplastic. You don't really want to go with a big stent at the first shot, because the MPA tissue is very, very thin and soft, and you put too big a stent, that might risk into the problem of erosions later. So the third pitfall is when you don't implant an adequate size stent. So this is again a similar 6 days old neonate with severe cyanosis. The PDA is very, very small despite prostaglandins. Therefore, we really had no choice, we thought. So we went ahead with the PDA stent, as we RVOT stent, and this is what it looks like. Very nice stent that goes across the annulus itself. We thought, well, this is a good position, and this is the 4 millimeter stent that we implanted. Within minutes of deploying the stent, expanded, it slipped downwards towards the inlet of the right ventricle. Then here, this is what it looks on echocardiography, that the stent has rested on the RV inlet, very, very stable. We thought we just leave it there. If it needs be, we would send it to the surgeon. Meanwhile, the patient is still very severely hypoxic, and therefore we can't really stop there. So we look for the PDA. Yes, it is still there, but very, very tight. But this PDA can only be stented safely with the axillary access. We managed to get that, and this is the stented PDA at the end of the procedure. And we just kept watching that RV stent that's sitting in the RV for about a week in the hospital. Even they're very, very stable. So we sent the patient home with very close reviews and had a successful surgical repair 6 months later. One more thing that I wanted to show, and this is very important. This is one of those cases done by our team, and this is not a simple TOF, but TOF with AV canal, and in a trisomy patient who is about a month old, 3.5 kilograms. So that is the RVOT, which is narrow actually, not that narrow, but it's narrow enough. And we had the JR catheter in the RVOT, wire pass across, and that is when the problem comes. It wasn't realized at that time, but what I'm sure you can see that, and in retrospect, this patient, the catheter has gone through a trabeculation instead of the true RVOT, and this guide catheter is inside those trabeculations. Nevertheless, because this wasn't realized at that time, so a 6 millimeter stent was implanted. And then we realized that, wow, we are in deep trouble now. This is the wire and the catheter in the true RVOT. So what we did was try to look for the PDA, which has basically closed, but there is still some opening there, very, very tiny. So this was recanalized, and then a stent was implanted. But this is the echo at the end of the procedure. There is a tiny rim of pericardial diffusion. Patient wasn't doing very well, and therefore a month after the procedure, the patient had surgical repair. Again, the post-operative morbidity was continuing, and the patient subsequently expired. So just to finish very, very briefly is the other end, the other option we have, PDA stenting. As I mentioned earlier, not all patients have PDA open at the time of presentation, which is often towards the end of the first month, unless they are severely hypoxic. And even if we give prostaglandin, it might not be there. But if they have a PDA, I think this is a good option because we can avoid going across all those delicate structures and complex 3D morphology of the right ventricle. Fortunately, because I'm not talking about TOF atresia, this is a totally different topic, but the morphology in phallus tetralogy with PS often is not as complex as TOF atresia, which we saw very nicely in the first talk by Professor Shi. It might come off from the transverse arch, but then again, multiple curves and kinks are not as common, and LPA stenosis, yes, but not as common either. And technically, therefore, it is more straightforward when you compare that to trying to stent a PDA. And the duration of palliation, it is a concern for this group of patients, but with phallus tetralogy, well, our surgeons are good at repairing this even as early as 4 months, then it's not an issue in terms of re-interventions interstage between the stenting and the surgical repair. So an example, so this is a patient with that kind of very severe spells with hardly open RVOT, but the PDA is also just barely open. Basically, it's closing despite prostaglandin, and what do you do? RVOT stent or PDA stent? Well, we elected to stent the PDA in this case because we thought we can still recanalize that with a wire, then inflate with a balloon. Sorry, that was a still picture. We used a small balloon first to dilate that PDA, which is closing. Then we implanted a stent, and here it shows very nicely that the PDA, the pulmonary arteries are confluent, fairly decent size, and no branch PA stenosis. And this is a good case, I think, to stent the PDA instead of going across the RV and face those kind of possibilities with RVOT stent. This is a more complex PDA in a phallus tetralogy with PS, who was dependent on prostaglandin, had NEC and short gut syndrome. So it's not quite ready for repair yet. And typically, like to many patients with phallus tetralogy, the PDA comes off more proximally from the transverse arch. If you do just a plain angiography on the AP, you can't really see it, but you really have to angulate it sometimes quite deeply in the aleocranial position to notice that there is a severe LPA stenosis, and therefore, in this situation, it would direct the stent towards the right pulmonary, towards the main pulmonary artery or to the right, and see what happens. In this patient, yes, there is spasm and more marked stenosis, but after a few minutes, we can see a nice flow into the left pulmonary artery as well, despite the gelling by the stent. And this is preoperative CT scan showing nice growth of both branch pulmonary arteries. So just to summarize, I think experience is accumulating. I think we'll be seeing more results being presented or published in the journals with regards to RVOT stenting. But at the current moment, PDA stenting has been well covered in terms of publications. Therefore, we understand better the morphology, the pros and cons, as well as the possible complications and how to deal with that. But for now, I think many are still on the learning curve part of RVOT stenting. PDA stenting has wide acceptance because of that, but I think the problem is that many patients present at an age when the PDA is no longer patent, but there is still a chance of stenting that if you try with prostaglandin and maybe try to recanalize a closing PDA. RVOT stenting, it is something that is more widely feasible compared to PDA stenting in fellows with pulmonary stenosis, but we need to understand that the RV has a very complex 3D morphology with many important structures along the path of what you want to do, and therefore these are the possible complications of injuring, for example, the tricuspid valve or causing perforations on the RV wall, causing tamponade. Therefore, the best thing is to use coronary stents for these patients. Also, to remind ourselves is that the landing zone of RVOT stent is contractile infundibulum, and if this is not anchored on the small pulmonary valve, then we need to be mindful that there might be a risk of stent migration, which in this case is difficult to retrieve in a small unit, and therefore we really need to be working as a team with your surgeons to be able to deal with this immediately. There are many pitfalls which I have shown earlier in my examples. For example, stents being too short once you deploy it either proximally or distally, and also things like stent migration, because we don't really size enough, we don't put enough adequate stent size to cover the RVOT, and therefore if we need to use bigger stent, we have no choice but to use those peripheral stents which require a Marlin's type of sheath, which then will lead to these other complications of injuring or compromising the hemodynamics in these sick neonates. What about sparing the valve? It is very desirable if you can do that, but in terms of safety, if you feel that the stent is not going to stick, it's not going to stay there, then I think you might have as well to cross the PDA, the annulus, and the pulmonary valves at the expense of not being able to spare the pulmonary valves. So I think PDA stenting is something that most people are familiar with. It's attractive because in TOF PS, the PDAs are not that complex and a bit more straightforward than pulmonary arterial with venous tetralogy. But then again, this option is not available in the majority of those who present say beyond a month of age. Thank you for your attention.
Thank you, Matthew. Great talk. In the interest of time, since we have overrun quite a bit, shall we move on to the next talk? And if we have time at the end of the sessions, we'll go back to questions and Matthew answer the online questions in the Q&A chat box. Thanks. I'll hand over to Joko.
Okay, I talked about that, Joko. Frank, why don't you open your slide? When do you move to Sacramento? University of California, Davis.
2018.
Oh, really?
Yeah.
How is it?
It's good.
How is your life? I saw that you were say happy life in that always. You're saying your happy life.
Oh.
So time is limited. Why don't you start your lecture?
Okay, well, thank you again to the organizers for inviting me. You know, when I realized that Mazini was on the panel here, I got a little intimidated because I think he's one of the world's greatest experts in PDA and RVOT stenting. So I'm not so sure I'm going to come up with any new tips or tricks that he doesn't already know. So hopefully this will be at least entertaining. Okay, so we're going to start with again, I'm going to start with the surgeon's role and then the interventionist role. We know that the surgeon's role is the BT shunt to basically establish pulmonary flow. And then, of course, some of the more aggressive surgeons will talk about early TET repair, usually with the transannular patch. The interventionist role basically is two options, right? We have PDA stenting and RVOT stenting. And again, just to start with the PDA stents first, there's very morphology of the PDAs. We're talking about the angles. They could be like a reverse angle or the normal angle like you have with every typical PDA. It can also be a straight 90 degrees coming off the aorta. So you can go from above or below. It could be very tortuous. Access becomes an issue. And of course, a lot of that depends on the angle of the PDA off the aorta. You can use the femoral arteries, the carotids, the axillary, even the UAC, and even through the RV, depending on that anatomy. So here's an example of some, again, not so much of a tortuous vessel. It's like an SC bend, which is pretty straightforward, but it's coming from above. So you imagine this will have to come in from either the axillary or the carotids. This has a little bit more of a steep bend, making that turn a little more difficult, but doable. This one is a little bit of a U-shaped bend, almost like an S bend here as you get into the MPA. Again, some of these has this sort of an S bend configuration on the lateral projection. It can become very horizontal at times. This one, it's a little bit more of a curve. This one looks like it's very straight, right? I'm almost like 90 degree off the aorta. And then, of course, you have some of these more typical ones. This last one, it's very tortuous. See, it's a very steep S bend. You can imagine getting the wire around that can be quite difficult. And in fact, can cause spasm, even thrombus formation as you're doing this. So some of these, you have to decide how you're going to do this, what's your best approach, and what is your backup plan. So again, you can use the right carotid here, you can use the left carotid, you can use the right axillary, you can use the left axillary, you can go straight up from the femoral, and then you can even use the UAC. When I have a UAC, and if the anatomy is easily coming from the aorta, I would actually use the UAC just to avoid injury of the femoral arteries. First, the decision-making process. We know that we have to determine the PDA orientation and the dimensions, we start with the echocardiogram. Now I put plus minus CT because I know that in the US, many centers will always go do a CT talking about how they can figure out the diameter and the length. I'm not so sure I need that. I rarely will ask for CT. I figured this out in the echo, and I also find that the lengths are going to be variable because it's going to change once you put the wire in. So I usually take a picture after the wire is in, see what that length is. And then of course, how do you position the table baby on the table if you're coming from the axilla or from the neck? We've learned that if we rotate the baby upside down, meaning the head is at the feet position, you have a lot more length in the table to use your wires. If you're coming from the head, you're going to have to put a second table at the head so that you can avoid losing the sterility. And it's much more difficult when you're working at the head of the table for those long wires coming from the neck. You have to make sure that you have all your stent sizes available, both in diameter and length, based on at least your estimated dimensions on your echo. Although I know echo is not the best place to do it, and that's where CT can come in handy. But if you have all your sizes available, you'll figure out what you need once you get your images. You should always have a plan B, right, for adverse events, and that includes spontaneous spasms and thrombosis formation. So you have your PG, you should have your surgical backup, and in certain situations where you know it's very tight and a high risk, you should have your ECMO on standby, especially for the very tortuous PDAs. So here's an example when we come across carotid approach. You see that the baby's head is at the feet of the table and the feet's at the head of the table. So you have a lot more length for your long wires. So that the blue arrow shows how much more length you have if you reversed it. So again, this is just with everything draped. And then of course you do your carotid cut down that way. You can use percutaneous, but we tend to do the carotid cut downs. So what's wrong with this picture? So this is one of them we learned early. You notice that the ET tube is too high, right? On the lateral, the elbow is too low. But keeping in mind, when you reverse the body, this drapes, the body's in the middle of the drape, not the end of the drape. So it's not so easy for the anesthesiologist to pick up the drapes and move the ET tube or move the elbow because it's in the middle of the table. So the best thing to do is make sure your ET tube is in good position and your elbow is out of the way before you actually start draping. So that was a mistake that I learned early on to avoid this in the future. The PDA length, again, I want to make sure that people know that it can change. The length can change once the wire is in, especially when it's tortuous. So you need additional angiograms with the wire in place to determine what size. If you're not so sure, it's better to overestimate and then to underestimate the length. I think that most surgeons don't mind that a little extra stent poking into the aorta or into the PAs as opposed to underestimating. You have to track your anticoagulation in order to minimize your risk for thrombus formation. When you stent, you have to make sure you know where the sheath tip is. That's a mistake I learned once that I will never forget again. Sometimes those sheaths may not have a radial marker, and if you don't have the sheath too far in, and we tend to worry about pulling it out of the carotid, so we tend to push it in further. But if the sheath is too close to the stent, you might actually cause a problem because the stent is going to be still being in the sheath. So you have to be aware of dislodging the stent even when you're starting to remove the balloon. Again, oftentimes we get the stent in, we're happy, we pull the wire out, but again, the wire can actually get you into trouble if you don't think about it and be careful at the end. So here's an example of the native tortuous S-bend curve, and you see this is what it looks like when the wire goes in, and then this is what the stent looks like when your stent is in. So again, I just want to caution that you can't always use the length from the native anatomy to determine the length of your stent. So this is what it looks like. Here's another example where this is a very acute bend, and then this is what it looks like after you put it in. See that almost like a double U turn, very steep S-bend, if you will. Once the stent goes in, it changes the shape, and therefore the length would be different. So this is what it looks like after you put the stent in. So this is what it looks like on, just to draw it out, this is what it looks like after you've finished. So this is the same patient. You see how tortured it is, and I want to show you that the wire is quite tortuous. You're going in because that part of the wire is very flexible. But if you can get it deep enough, the stiff wire comes in, it'll just all straighten out. And again, I think that in infancy, that those vessels are very compliant and they'll change shapes as you put the stiffer system in place. So this is what it looks like afterwards. You notice that there's not much flow through that. Well, actually, there is flow through that. And so therefore just pay attention to that the tortuosity and the length could be very different. So in this case, you see that the PDA is quite perpendicular to the device. So we came in from from below. This, I think, was the one that we put in the UAC. And again, the orientation is not much different when it's straight across like that. But you see the curves will also straighten out. So again, you have to be very careful where the tip of your sheath in. Here's an example where when I put the sheath in, I wasn't paying attention where the tip is. So as you inflate this, let me show you what it looks like as I expand it. You notice that the radial marker of the balloon is still inside the sheath. So after we finish, the very distal part of the stent actually was still undilated because it was still in the sheath. So that's one of the things that you have to pay attention to when you're ready to balloon. Make sure the sheath is far back enough so that balloon can fully expand. Luckily in this, we actually put in a new balloon, a new coronary balloon, a tiny one, just to open it up and then gradually get up to a point where we're able to open everything up. Again, this is a dodge bullet, if you will. So pay attention to the tip of your sheath, especially if you don't have a marker in. That's the patient. Again, this is that's just the same patient. Sometimes it's good to have a buddy wire to keep your stability. So again, I'm going to go over a little bit of some of the stents that are available, and wires and microcatheters can be very helpful in some of the tortuous PDAs. You have to be aware of wires getting stuck in the PA afterwards, and I'll show you an example of that. Using the CTA, I know that there's some advocacy for it and there's some value to it, but the question I have is that do we really need this, and do we need it for every single patient? So here's an example of a very tortuous tight PDA with the stenosis as it enters into there's probably a ductal cord involved in the LPA. You notice that after we put the stent in, the wire had come back a little bit, and I had trouble getting it back in. I knew that the stent, there's a little part of the distal PDA that was not stented. So ideally, I need a stent to be further in, but this wire was not in the best of positions at this point. So when we knew that, I didn't want to pull out the wire, so we ended up putting a buddy wire in here, and then with that, we can remove the second wire, and then we're able to put a stent a little more distal to it, and not the ideal setting, but at least it saved us. So having a buddy wire can really help you to get yourself out of trouble. So that's the pre and the post. Now, one of the techniques that I've learned from Dr. Mullins is the ability to heat curve the catheters. This is an angle glide catheter, and I put a curve on the wire, and I put it to a heat gun, just heat it up, and then put it in cold water. And this is what it looks like after you moved it. You basically can create a new curve. That's what it looks like. So this is the original curve, and this is the new curve with the heat gun. So again, you can actually modify your catheters using a heat gun for the purpose of getting into the ductus, depending on the curve you need. I'm going to talk a little bit about the Osiro Biotronic stent. It is the thinnest of the coronary stents. It's about 80 microns thick, whereas most of the coronary stents are about 120 microns, and it's the most flexible. Now, there's been a lot of discussion that when you have tortuous ductus, do you use a stiffer stent or a flexible stent? And I've heard a lot of discussion about using the stiffer one to keep it straight, but actually, I think it's counterintuitive. You actually want a more flexible stent so that it can bend with the curve, so that when the heart contracts and there's some curve created by the contractions, the stent actually bends rather than resist. And I know that in the adult coronary world, when they have a tortuous coronary, they actually would rather use the flexible stent, which makes sense to me. So again, it's a little bit of controversy, and it's counterintuitive. When I find that when I have a very tortuous, I will use the Osiro Biotronic stent. Again, a little bit about angle guide catheters, microcatheters over and 4 wires, and I'm going to talk a little bit about the steerable microcatheter. So this is the what we call the Supercross 90 and 120s. You know that, notice the angle. These are microcatheters that take a 1/4 wire. It can go through a 4-French sheath. So again, if you put an angle guide catheter, you put the microcatheter into that 4-French guide catheter, then the 014 wire, you can slowly create a better curve if you like, if you need. And again, it comes in 90 degrees and 120 degrees. And having this in your cath lab can be very helpful to help you get into the position you want. So here's an example of a pretty straightforward stent, but again, because of the 90 degree, I just put a Supercross in. This is Supercross 90 to get in there, allow the wire to get into position quite easy, and they were able to stent it quite easily. Now, this is the steerable microcatheter. It's called the venture catheter. It goes through a 5-French sheath. It takes a 1/4 wire. It can deflect up to 90 degrees. So you can put that in, steer it to the angle you want, and then run your wire through. Now, of course, so you can see how I can put the wire there. If that's what the angle, if I want to change the angle, I can rotate a little bit more, and then I can change the angle of the insertion for the wire. So this is a very helpful device in your cath lab. It's a steerable microcatheter. So that's the example. Now, some people will say, well, this goes to a 5-French sheath. I don't want to put a 5-French sheath into a baby. Well, guess what? The new Swift Ninja catheter has the same features, and it goes through a 4-French catheter. It takes a 1-4 wire, and it actually goes bidirectional. Here's an example. So this is a 4-French catheter. I can bend it one way, and I could bend it the other way. So it's got 2 directions to tip it. So it's called a Swift Ninja. And I found this to be quite helpful in some cases. I don't use it all the time, but when I'm really stuck and I can't get in, I find that this can be helpful to get your 014 wire into place. So here's an example of we're going back in. I had trouble getting in because the stent was actually a little into the aorta. See how I can actually steer it in and get it to the way I want it to get in. So therefore, it can be very helpful at times. So here's some of the Osiro Biotronic catheters, stents, I mean. Again, as I said, it's a 80 micron thick. It's very flexible. It moves with the contractions of the heart. And I found that this, at least I use this for the very tortuous ductuses. I also have the everolimus, Synergy, and Zion stents. Again, I know that there are many different drug-eluting stents available, but I don't think there's enough data to show one is better than another regarding PDA stenting or the prevention of in-stent restenosis. One of the things that a lot of adults like to use is rapid exchange design where the wire comes out of the side of the wire. I don't really like them only because I don't know how to use them as quickly as the adults. And since we don't always have long sheets in there, I just rather have the through the middle, over the wire. It's a tradition, but most of the adult coronary stents come with this sort of rapid exchange design. So here's an example of, again, I'm done with this and I'm pulling on it, but again, I'll watch very carefully. Look at the lateral projection. As I'm pulling on it, the tip of the wire is stuck in the stent. You can imagine if you don't pay attention, you just pull, you're going to break that stent or bend it or get it out of shape. So be very careful, even at the end when you pull out wires. Here's an example. So then we actually push the wire back in, rotate it to get the curve out, and then with that, we're able to pull it out without causing a problem. So again, you just get yourself out of trouble by watching carefully, even at the end. Now, this is an example. Again, this is from my colleague, Henry Justino, who had put a PDA stent in to see how tortuous this was, had a great result putting a stent in. And what happens is that looks great, right? So now you're ready to come home. And guess what? He's pulling on this. He actually had rotated the wire so that it locked it in to get it positioned so you can put your stent through the sheath. But at the end of this, I forgot to unrotate it. So you can imagine as he's pulling on this, the wire is out, but guess what? The distal tip has still stuck in there. And this is what happens. No matter what, he couldn't get it out. And eventually the stent clotted off and that kid went to surgery. But this is what happened. The wire actually just unwind over the core. Again, the key thing is that even at the end, it's not over until it's over. And it's over only when everything is out of the body. So don't let your guards down. Be very careful, even at the very end with the wires coming out of the stent. In-stent restenosis, I think Mazini has talked about this. That can always happen, but it sees, when you put the stent in, if you have it too deep in the aorta, getting back in is not so easy. So therefore, make sure that you realize that if you have the stent in deep into the aorta, getting in may be difficult. So here's an example where we use the angle glide catheter to get away from the stent and then put in a supercross to turn back into the stent. So just to stay away from the edge, from getting into the side, but moving away to the tip and then angle it so that you can get back in. So using a combination of these curves, like an S-bend, using between the two catheters and the microcatheter, you're able to get back in. Eventually, we're able to get back in, and then we have to put a very long course just to get the stent back in. This is to try to redilate that in-stent restenosis within the ductus. Eventually, we pop it in, and now we're able to inflate the balloon there. In fact, we added a second stent in, and so therefore this is the pre and the post, and so it looks fine. Okay, now I'm going to talk about RVOT stents, some of the tips and tricks. Beware of the angle changes caused by your wire. You have to note what the native RVOT angle is. Make sure that when the stent is actually truly across the os infundibulum or any other muscles that may protrude in the stent. Here's an example. Of course, we have to learn how to take care of TET spells, right, during the cath when we're doing this. Again, you talk about PGE, volume, ephedrins. Again, you may also need to have ECMO on standby for some of the tortuous ductuses. Your RVOT stent is basically to buy enough time for somatic growth before surgical repair. It's also useful when you have hypoplastic PAs, just to grow that vessel a little more for the surgeons to do the repair. So I'm going to talk a little bit about the types of stent. I mentioned earlier the Megatron stent is actually very helpful. It's a 4 French coronary stent. stent, but it actually can go up to almost 5.5 millimeters in diameter. For the larger kids that you can afford to use a 5-French sheath, I've tended to use the Palmaz Blue stent. I know there are other options. You can get to about 8 millimeters if you actually need that big, but those need a 1 French larger. Again, we talk a little bit about over-the-wire versus rapid exchange types of stents. And then, of course, there's always the option of hybrid approach versus cath lab approach, depending on the patient. We talked a little bit about instant restenosis. There is an example of the muscle bundle underneath this TET. And you see how that's the stenosis there. And you can imagine that that's the area that we're going to have to stent open. And so this is the picture of the wire and the stent having gone in. Now, just look at the first picture on the left of the panel with the wire still in place. And notice that after we remove the wire, there's an angle change, right? See how this is the infundibulum, where it was pointing more horizontally, but it changed after the wire was moved. But more important, look at the stent. This is what it looked like with the wire. It's aligned with the wire, so therefore it looks like it's free from the muscle. But once we pull the wire out, it became more vertical. And that was more the native position. So you can see how when it became more vertical, suddenly that muscle is sitting underneath the stent. And now you can bet that this is going to cause restenosis. So pay attention to the angle so that when you put the stent in, know what it looks like, know where the stent should end, and don't just assume that with the wire in place, that's going to be the anatomy. Because when you pull out the wire, it will change. So see how that it tilts once everything is out of the system. So the same patient on the left is the stent with the wire. On the right is the wire removed. See how the angle has changed, and look at the on the other one as well. So you see it becomes more vertical when you take out the wire. Again, that can then sit in front of a muscle, and you'll be in trouble because there'll be restenosis. So this is another example. This is a 34-week preemie who now weighs 2.18 kilos, also has fallow seal. So you can imagine the surgeon wanted to wait a little longer, tight stenosis. We end up putting the stent in, and 2 months later, SATs are lower, and you have to go back in, and sometimes you'll see this sort of muscle bundle underneath the valve. I think Mazini's talked a little bit about that. As much as you try, sometimes it's not enough, but without having to go to surgery, we're able to get back in there, open that up, and open things up. So again, know that some of these can develop muscles underneath in spite of your best attempts. That's the before and that's the after. This is the Megatron stent that we talked about. You can see how it comes in 4.5 and even a 5 millimeter length. But if you look at this part here, where actually when you go higher pressure, it could go as high as 5.36 when you go up to 16 atmospheric pressures. And you can actually go up even higher because the balloons can actually handle higher pressures. So you can use this to get up to about 5.5 millimeters if you need to. Again, these go through a 4 French system, which is very useful. That's my go-to stent these days for RVOT. For the bigger patients, we talk about the Palmaz Blue stent. This will go through a 5 French system, and it's very, very useful. I think that the other stents available outside of the US that we don't have access to, I'm sure we can discuss about what are some of the best stents you guys use. 2-month-old came in with RSV, desaturated. The surgeon didn't want to operate given the RSV, so therefore they wanted 6 weeks for the kid to heal before going to the operating room. That's another indication, even though the kid's big enough to have a surgical repair, but because of an infection decided to hold off. So we put the stent in, and then we were able to wait 6 weeks later, and then the kid's lungs healed, went to surgery, and had a pretty easy post-operative course using the technique. Here's an example of a kid with TET and severely hypoplastic PAs. You can imagine surgeons don't want to operate this unless the vessels grow. So we can put a balloon in and put a stent in place, and then of course you see this. Later on, it looks like it's a lot better. There's a better flow to the lungs at this point. Comes back in a few months later. There's more growth of the vessels. We further dilate it. In fact, we noticed there's an LPA stenosis on the lateral projection. Ended up putting another stent there. Waited a little longer, but we're able to get him from that to that, and with that, the patient was able to get to surgery easily. So let me just summarize. Interventions play an important role in the management of TET patients. RVOT and PDA stents can maintain pulmonary flow while patients grow to the size large enough for cardiac repair. You can buy time for the hypoplastic arteries, pulmonary arteries to grow, and you can also buy time for infections to clear before surgery. Thank you for your attention. I'm going to unshare.
Thank you, Frank. There are some questions in overlap the question for probably Mazzani's talk. And the one is a say, and how do you tortuous PDA? How do you decide it for the say stent length for that your trick for that decision for that?
So that's why I don't use the CT scans to look at it and say that's what I'm using. Now, luckily, I'm in a lab where I have all the different available stents. And so therefore, I'm not that worried that we will not have a stent. As I said, if I'm going to estimate, I'd rather overestimate than underestimate. But there have been plenty of times where I've underestimated. But if I'm going to underestimate and realize it, I'm going to put the stent distally and overlap it proximally, as opposed to do it proximally and go through the stent to get to the distal. But oftentimes, once the wire is in, I would actually take another picture because I want to see what the stent length looks like with the wire still in place. And that's what I decide, because the stent is going to be even stiffer than the wire. So I tend to more rely on what the anatomy is once the wire is in.
Thank you. And question from Jonas. And PDA that you stent based on your anatomy, is there anatomy and
so I think Jonas is asking, is there a PDA that I would not stent, right? And I think that the ones where I would be very worried are the ones that are very tortuous, and that's the only source of pulmonary flow. You know, of course, in TET, oftentimes you have two sources of flow, so you have a little bit of a backup. Certainly in the ones that where it's very tortuous and you have the only source of flow, if I was to do it, I would make sure there's a ECMO circuit on backup, even though I know that's a lot of cost and maybe not needed, but I rather have that bail out quickly than not. The one I showed you, of course, that was a tetralogy for low patients, so therefore you had some forward flow, and so I was able to get through. And I didn't show you some of the pictures that actually the first stent that went in, I underestimated the length, so therefore there was not much flow through the stent, and the sats had dropped. And I realized that the aortic end of the stent was the ductus was not stented. I had to quickly add a second stent in to open it all up. But certainly, and how do I know when it's really tortuous? My criteria is that when the echo cannot show the entire length of the stent from the aorta to the PAs in one view. If they have to scan back and forth like as if it's a corkscrew PDA, those are the ones I have a hard time with, and I'm really worried about those. So in that scenario, of course, if it's a TET, I would just stent the outflow tract instead. But there are times when I can't see the entire course of the ductus in one frame, then I know it's a little bit of a corkscrew, and I worry about those.
Okay, thank you, Frank. I pass this microphone to Joko.
He is my grandfather.
Or host yeah.
He was my great honor to introduce the next speaker, Professor Jing An from Taiwan, National Taiwan University Children's Hospital. Professor Chen is very smart and creative young guy. He got many awards and awards and published many scientific papers. Professor Chen, please.
Thank you, Professor Wu, for your kind introduction. Can you hear me? Is that okay?
Okay.
Yeah. Thank you. Okay, I'm Jian Chen. I'm going to share a few cases of TOF neonatal stenting, including PDA stenting, alveolar stenting in our institute. Oh, okay. I have no disclosure. Actually, I have to admit that I'm not even a big fan of PDA stenting or alveolar stenting, because as you know, the surgical shunt has already been performed for more than 70 years. So should we change this this strategy? This is a question we have for a very long time. Until recently, more and more publication has published to show actually the PDA stenting or alveolar stenting may have benefits over comparing to the surgical shunt in terms of hospital stay or the midterm mortality. So this is the strategy we used before in our institute. If a patient is really in good condition, the patient may have a neonatal repair in newborn stage. The most baby, if not have such a good condition, may receive surgical shunt. But until 2016, more and more data coming out, we start to think about if we can do some palliation, catheter-based palliation for this patient. So this is the algorithm used in our institute. Maybe this different institute may have different policies. If the patient has already have VSD and pulmonary edus is not so small, and the alveoli is muscular atrophic, so the patient will still consider a candidate for surgical shunt. Or if the PDA has more than 2 acute angles, or is there significant branch PA narrowing, we still send patient to surgery. If the patient don't have this contraindication, then we will start to think about the possibility of alveolar stenting or PDA stenting. So let's look at this patient. So this is a 1-month-old baby, body weight nearly 3 kilograms, referred to our hospital because of frequent blue spell in spite of high dose propranolol and high dose PGE1. And the PDA is actually small. So as you can see, alveoli is elongated and narrowed with a pulmonary annulus around -2.5, and the VSD is permanent type. We always get a CT before considering about catheter-based intervention in our institute. So as you can see from the CT reconstruction, this is small tortuous PDA from distal transverse arch as or PDA as OTOF patients. But actually it's not very long and there's no acute angle. And the PA size is suboptimal for total correction and there's no significant branch PA stenosis. So based on this algorithm, the patient certainly can have the PT shunt. And because the pulmonary annulus is actually not so very small, so maybe alveolar stent is not a very good choice. So after the discussion with the family, we decided to go for PDA stent. And we use this is Philips, the software developed by Philips, the Vessel Navigator, to reconstruct the CT imaging so that we can have a better understanding of the PDA morphology. And more importantly, you can have a better decide the best angle for intervention before intervention. And so this image can be used to guide the intervention during procedure. So because the patient is very highly PGE1 dependent, so we still use a very relative high dose PGE1 during the procedure. So this is the angiography. You can see the PDA here is very similar to the CT findings. However, when we try to close the PDA using a soft conic guide wire, you can see the PDA spasm. So we can get through the PDA even with the assistance of a microcatheter. So we increase the dose of PGE1 to 100. Although of course the patient has severe hypoxia at that time. So we are lucky to pass the soft guide wire. And then we exchange the soft guide to a stiffer conic guide wire using a microcatheter. This is the PDA, the straightened PDA length. It's roughly around 7 millimeters. So we use a 9 millimeter long bare metal stent to stent this case. And 5 months later, as you can see, the patient has the fair growth. However, the pulmonary annulus remains small. And this is the CT since maybe 5 months after PDA stenting. So we send the patient to surgery. So the surgery was performed at 6 months old at 6 kilograms. The patient unfortunately still underwent a transcatheter patch because the surgeon thought that the annulus is still too small. And the surgeon told me that there's severe adhesion around the PDA stent, so he can only partially remove the stent. Fortunately, there's no obstruction to the LPA flow, so there's no need to perform LPA plasty. And I will going to go to talk about more about my contraindication for PDA stenting. That is having more than 2 acute angles. So this is an example. So this is a patient with extreme tetralogy fat load and also a low body weight. As you can see, the CT imaging nicely show how tortuous it is, and this is a very long PDA. Sorry.
Dr. Chen, are you muted? We can't hear you.
Oh, okay. Can you hear me now?
Yes, thank you.
So actually, this is my personal opinion. I think the PDA having this kind of morphology that's long, tortuous, and more than 2 acute angles, I would think it's still a very big challenge for me under current stent technology to do PDA stenting. Okay, let's go to the next case. This is a premature baby with body weight only 1.2 kilogram, and he's PGI dependent for a very long time. But unfortunately, he developed frequent blue spell when body weight approaching 2 kilogram. The PDA is very small, even under very high dose PGE1. The point valve area is around -3. So based on our algorithm, I think the patient have 3 viable options, that is alveolar stent, PDA stent, or BT shunt. Sometimes it's very difficult to choose between these options, but one night he developed severe pulmonary hemorrhage like this. This is the gesture is very terrible, and saturation is very low. So actually, this is critical condition makes decision easier because I think the either BT shunt or PDA stenting may do more harm to the lung. So I decided to go for alveolar stenting when pulmonary hemorrhage start to appear. Stop. Yeah. So this is the angio at the 2 kilogram. Like you can see, the alveoli is very, very narrow. So this is the I put a bare metal stent is a coronary stent 4.5. And 2 months later, when the patient body weight approaching 3 kilogram, you can see there's significant instant stenosis. But actually, this is part of our initial planning, that is serial dilation. So I dilate the stent, but the effect is not very good. So I restenting using a Cook formula stent that's up to 5 millimeter. Actually, initially, I noticed that I spared the pulmonary valve at the first procedure, but after I put a second stent, I think the pulmonary valve, yeah, it's closed. Actually, I think this is the best choice for this patient. So I will briefly summarize our institutional data since 2016. We have performed 21 cases with complex PDA stenting. That means it's not a simple PDA from distal, either from transverse arch or from inguinal artery, any others. So you can see there is significant learning curve because in our earlier 10 cases, the freedom from surgery due to hypoxia hypoxemia before next stage operation is not good. But in the since 2020, our the free-form intervention is much better. And this is my own case. I did half of this case in our institute. Yeah, actually, you can a similar trend. You can see the significant poor outcome in my first 3 cases. But after quite a learning curve, I think the outcome is much better. And this is the alveolar stenting in our institute. Similar learning curve is also observed. So since 2018, all of our patients with alveolar stenting don't have to need additional surgery for hypoxia before next stage operation. But of course, that is at the expense of increased recancellation, as a restylation or restenting. But I'm happy to see that many hospitals starting to push new boundaries. That is, their first priority to palliation is the PDA stenting or alveolar stenting. I think that this is something we're looking forward to see their outcomes. So far, I still can say that I'm a big fan of neonatal stenting, but I hope with more and more data coming out and with new technology of this stent design, I hope someday I can say, yes, I love stenting. Thank you. Start sharing.
Thank you, Professor Chen, for sharing us this interesting case. Because the time schedule is quite delayed, so I will trace the host to Professor Jonas for closing remark. Professor Jonas, please.
Thank you. It is my great pleasure to deliver the closing remarks of this very educational APPCS 2022 forum. Indeed, we learned a lot from our distinguished experts from our region. I'd like to thank all the speakers and moderators who have imparted their knowledge and experience on catheter-based interventions in tetralogy of Fallot, which is the most common cyanotic heart disease in our practice. From the imaging, balloon angioplasty, and stenting of RVOT and or PDA, we are enlightened on how we can stage palliate our high-risk patients that will make them better candidates for total correction or address post-operative issues. The various effective ways of managing our TOF patients is important since they will be with us from birth to adulthood. Some interventions like RVOT stenting can be extended to older children nowadays to improve their quality of life and increase their chances of operability. This is important, especially in many low to mid-income countries with limited resource settings where surgical intervention can be delayed or limited. I also would like to take this opportunity to invite everyone to the 9th APPCS Congress, which is scheduled on February 23 to 25, 2023. The upcoming purely virtual Congress is entitled Innovations and Solutions to Complex Cardiac Problems in Children, which will focus on game changers and best practices of pediatric care in the Asia Pacific. Our speakers, of course, will be leaders in their field, some of whom are in this forum. We will send a link to our official website very soon. We also would like to encourage everyone to submit their interesting case reports and research studies. The deadline for submission is on October 31, 2022. Finally, I would like to thank the Taiwan Society of Pediatric Cardiology, led by our good friend, Dr. Joku Wang, for organizing this event. To you, dear colleagues and fellow students of pediatric cardiology, thank you for attending this scientific forum. Wishing you all good health and a happy weekend. Maraming salamat po.
Okay.
Thank you, Jonas.
Thank you.
Thank you, everyone.
Goodbye,
very
everyone.
much.
Bye-bye.
Have a nice weekend. Bye-bye.
Everybody.
See you next time.
Maybe we should have like a
beer.
maybe a group shot.
Sure. Can we have a Photoshop?
Bye-bye.
I think we are complete. Can we have a shot now that we have more people? Frank,
Yeah, let's do that. Let's do that.
let's turn on the camera.
Okay.
One more.
Okay. Frank, please make sure you
Thank
send
you.
it to all of us. Yeah.
Right.
Absolutely.
Hang on.
Thank you.
Hey,
Okay.
sorry, I just got on. Can you hold on? Let me get one also.
Yeah.
Give me a good smile, everybody.
Smile.
Ready? Good smile. 1, 2, 3. Smile. Big smile. All right. Very good. Thank you very much, everybody.
Okay.
Bye.
Thank
I'll send
you.
it to
Bye-bye.
Nicole.
Have a good
Take
weekend.
care.
All right. Bye-bye.
Bye.